Good day. I'd like to thank Dr. Biswas and the AIOS Scientific Committee for the invitation to give this talk. I'll be presenting something new that we've been working on in Singapore over the past 2 years. Corneal scarring can be caused by a variety of insults to the cornea, including infections, inflammation, or corneal dystrophy, and it's a leading indication for corneal transplantations. However, there's a fundamental limitation with current corneal transplantations. The number of transplants is limited by a global shortage of suitable donor corneas. A global report indicated that only 1 in 70 of the overall needs of corneal transplantations are met. Some reasons include low endothelial cell count or lack of availability for serological testing. The utilization of donor cornea is such that 1 donor is used for 1, 2, or at most 3 recipients. Other problems with transplantations include high surgical expertise and cost, the long visual rehabilitation process for some transplantations, and the risks of immune rejection and graft failure. With the limitations of transplantations, there is thus a drive to search for alternative, more scalable treatment modalities to meet the global demands for corneal transplantation. Such modalities must be less reliant on donor tissues, are less invasive, and technically less challenging. Current research focuses on 2 main areas: regenerative medicine, where cells are made to regrow or repair to replace diseased cells and thus restore physiological function, or scalable options such as cell-based therapies. The majority of transplants are performed for corneal endothelial diseases, followed by stromal diseases. As mentioned, the 2 areas of potential therapies for corneal diseases are regenerative medicine and cell-based therapy. I'll be presenting our preliminary work on the use of mesenchymal stem cells-derived exosomes as potential therapies for corneal scarring. Mesenchymal stem cells are multipotent progenitor cells that originate from the mesoderm of many tissues, including bone marrow, blood, liver, spleen. They have a capacity to self-renew and ability to regenerate differentiated cells. Due to the potential role in regenerative medicine, immunomodulation, and neuroprotection and anti-tumor effects, the use of mesenchymal stem cells as a therapy have emerged as a popular research topic in recent years. Their effects have been originally attributed to direct cell replacement. However, studies have reported that MSCs are mostly cleared, while a small proportion will integrate into injured tissues after intravenous injections. Various hypotheses have been suggested with regard to the mechanism underlying the therapeutic potential of mesenchymal stem cells, and these include the transfer of mitochondria or exosomes, packaging a wide variety of different molecules. Exosomes originate in the endocytic cycle, and early endosomes experience inward budding and form intraluminal vesicles, where they develop into late endosomes or multivesicular bodies, which may either fuse with lysosomes for degradation of content or fuse with the plasma membrane to be discharged to the extracellular environment. And these extracellular vesicles are the exosomes. They are a family of nanoparticles between 30 to 100 nanometers, and they're thought to be enriched with endosomes-derived components and many bioactive molecules, including protein, lipids, and nucleic acid components. As they are released from multiple cell types, this suggests that the secretion of exosomes is a general cellular function important in the intercellular transfer of information. In recent years, the therapeutic potential of mesenchymal stem cells-derived exosomes have been investigated for systemic diseases including liver, cardiopulmonary, and neurodegenerative diseases. Various preclinical studies have also showed the potential therapeutic effects of exosomes in ocular diseases. For corneal diseases, research into exosomes from various cell sources have been used, including corneal stromal stem cells, corneal stromal mesenchymal stem cells, and umbilical cord mesenchymal stem cells-derived exosomes. We hypothesize that topically administered human mesenchymal stem cells-derived exosomes can alter corneal wound healing and modify the density of corneal opacities. Our exosomes came from our collaborators at A*STAR Institute of Molecular Biology in Singapore. The exosomes were collected from the conditioned media of human embryonic stem cells-derived mesenchymal stem cells. They were then concentrated and fractionated to yield the exosomes of 1 milligram per liter conditioned media of 10 to 11 cells. They were assessed for characteristics exosome markers such as CD9 and CD81. The first step is to evaluate the optimal dosing frequency for topical exosomes. I'll explore labeled exosomes were topically applied to normal rat corneas in epithelium-on versus epithelium-off models. For distribution and dosage intensity studies, confocal laser ophthalmoscopy was used to assess the time-lapse tracing of labeled exosomes. Topical administration of labeled exosomes to epithelium-off models showed signals retained for 24 hours and a time-dependent clearance with a half-life of approximately 3 hours. Exosomes applied every 3 hours maintained signal over 50% peak intensity. In contrast, there was a rapid signal disappearance of less than an hour was observed in epithelium-on corneas. Having established an optimal dosing frequency, we moved on to evaluate the effects of topically applied exosomes to our established rat stromal haze model. Stromal haze was induced using irregular PTK or phototherapeutic keratectomy, and exosomes were applied 6 times a day, which is every 3 hours, and normal saline were used as controls. We used this stromal haze grading scale to assess the degree of scarring. Rat corneas develops haze within the first week following PTK and takes around 3 to 4 weeks to reach peak levels. And this experiment targets the early haze development period. Corneas were significantly clearer in the exosome group compared to control saline group. We also observed less corneal neovascularization in the exosome group. By quantifying these vessels, we showed lower vessel length, percentage quadrant of involvement, and area of vascularization. Immunostain also shows less angiogenic markers expressed and significantly lower vessel width compared to controls. This shows that application of exosomes have an anti-angiogenic effect following corneal injury. There was also less expression of fibronectin in the exosome group, which may suggest a dampening of the fibrotic response. There was also less expression of COL3A1 and alpha SMA in the exosome group, which are markers of myofibroblast differentiation. Flow cytometry also showed a lower number of alpha SMA expressing corneal cells. Thus, we have demonstrated the anti-angiogenic and anti-fibrotic effects of topically applied exosomes in our injury model. Assessing the excised rat corneas at day 5 postoperatively, in the exosome-treated group, there appears to be a higher CD163 to CD80 ratio. This indicates a more significant state of anti-inflammation or tissue repair when exosomes are applied, suggesting an immunomodulatory effect of the extracellular vesicle. In conclusion, we showed that topically administered embryonic stem cells derived human mesenchymal stem cells derived exosomes are potential therapies for corneal opacities. We've established an optimal dosing frequency for topical exosomes. The corneal epithelium appears to impede exosome permeation. However, prolonged effects on epithelium-on cornea still needs to be established. The permeation of topical exosomes also needs investigations, and it may be that stromal injections may be more suitable for deeper scars. We showed significant suppression of corneal neovascularization, stromal fibrosis, and inflammation. Currently, we are performing ongoing studies to understand the mechanism of action of these exosomes, which is the attributes of the exosomal cargo. The differences in therapeutic effects of other cell sources of exosomes is largely unknown, such as those derived from corneal stromal stem cells or other mesenchymal stem cells. I'd like to thank Professor George Mehta and his Tissue Engineering and Cell Therapy group for this work. Thank you very much.